Good evening, everyone, and welcome. Thanks so much for joining us this Wednesday evening for this virtual UMiami Health Talk, what you need to know about diabetes. And from the look of things, hundreds of you are joining us this evening, and it's a topic that is of great interest. I'm health journalist Ileana Bravo, your moderator for this evening's webinar, which is presented by UHealth's Comprehensive Diabetes Center. Our center offers leading expertise from a multidisciplinary team treating patients with type 1 and type 2 diabetes, secondary and genetic forms of diabetes, highly complicated diabetes, and even diabetes during pregnancy. They have customized treatment plans that fit into your lifestyle, using the latest advancements in diabetes care, including promising new treatments through clinical trials. Expert care and a full range of resources to make living with diabetes a little easier. Please learn more about UHealth's Comprehensive Diabetes Center by visiting umiamihealth.org/diabetes and call 305-243-3636 to schedule a consultation and screening. Don't worry, that number and everything's going to be up again at the end, including a QR code that you can take a picture of your screen. So tonight, what a privilege. We have two top experts who will discuss the latest breakthroughs in diabetes treatments and interventions. And at the end of the presentation, it's your turn during the Q&A session to ask direct questions of our experts. Use the Q&A feature at the bottom of your Zoom screen, which I've seen some of you have already learned, to enter your questions, and we will prepare them for our panel. So now it's my pleasure to introduce our first speaker, Elizabeth Ferrer, a registered dietitian and certified diabetes care and education specialist at the University of Miami Comprehensive Diabetes Center. She specializes in diabetes management and technology, helping patients improve their quality of life through personalized nutrition and wellness. Let's get ready to welcome Elizabeth, who will be sharing her screen with us now.
Perfect. Thank you so much, Ileana. Let me go ahead and get my slides ready. Perfect. And I will be in presenter mode. Perfect. Hi, everyone. Thank you for attending today. As Ileana mentioned, I'm the registered dietitian and diabetes educator at the University of Miami at the Comprehensive Diabetes Association. And we have here the ADA diabetes plate method. And what I want to review with you today is how we can make changes with your nutrition to help manage your diabetes with both type 1 and type 2 diabetes alike. So what we have here is the diabetes ADA plate method, which is a visual tool that we want to try to use to help kind of manage what you're going to eat and meal planning. Meal planning can be extremely difficult depending on what you have available, what you like, cultural factors, and access as well. So what we can take away from today, you can also use in your day-to-day. This is the plate method, which is a little bit different than the USDA MyPlates. This is from the ADA, which is the American Diabetes Association. And there's 3 compartments to the plate that we want to visually think of when we're kind of making our meals. So you'll see here half of the plate would be comprised of the non-starchy vegetables, and then the other half of the plate we're going to split into 2, as a quarter of the plate being the protein and the last quarter of the plate being your carb or your starch. So when it comes to diabetes, we do want to manage the amount of carbohydrates because that is the macronutrient that is affecting the blood sugars the most that's on this plate. So the biggest adjustment that I'll typically see with most of my patients and clients are that instead of half of the plate being, let's say, like the pasta or your carb or starch, we want to kind of make that adjustment and switch by not completely removing that carb or starch from your plate, but reducing the portion of it and then making space for something that will keep you feeling more satisfied, which would be those non-starchy vegetables. And we'll see in just a minute a little bit of this examples of how we can kind of make these adjustments and changes. So the same plate that we're seeing before, more in a general perspective, you'll see here a little bit more in detail and how you can kind of use this as a key to mix and match and really make that plate your own. So what you see here again is the half of the plate, those non-starchy vegetables. So those can be comprised of like cooked vegetables or raw vegetables. So if it's more raw vegetables, that'll be like a salad with your leafy greens, tomatoes, onions, peppers, or they can be a cooked like veggie medley with like broccoli, cauliflower, carrots, and things like that. So the fiber really does make a difference, and fiber will be your friend. I always like to say that because it does help to bring down the postprandial blood sugar. So our blood sugar is going to go up after we eat. It's going to happen to anyone. But with someone who has diabetes, the point to make with how we can make these differences with like your nutrition is to not have that spike be so high or so aggressive or stay so high for too long. So we definitely want the blood sugars to start to trend down as quickly as possible. So the fiber really does help there. Moving on to the other section of the plate where we have the protein and the carbs. Protein, we can think of course, animal sources, but we also do have a lot of non-animal sources that you see on the plate on the bottom right-hand side. So we have things like chicken, fish, salmon, beef, the eggs, cheese, and then non-animal sources. Nuts also have a good source of protein, nut butters, and tofu as well. Now, the last portion that we have is the quarter of the plate with your carb or your starch. And I say carb or starch because typically we think like, okay, I'm going to have a vegetable, I'm going to have a plantain, or I'm going to have sweet potato. But we want to really consider those more as your carb and comparable towards like what you see in that corner of the bread, pasta, and rice. So we typically think, oh, I know bread, pasta, and rice have carbs in them, so I want to try to limit those. But there are some kind of hidden foods that we can see now that they do have a lot of the carbs or starches in them. So things like sweet potatoes, malanga, yuca, squash, regular potatoes as well. Fruits, juices also have a carb, are considered a carbohydrate as well as a simple sugar. And also things like beans, peas, and lentils, both are kind of a carb and also have a little bit of protein as well. The milk and yogurts are something that a lot of people kind of will skip, especially if you are someone that has to do a lot of carb counting. So we do want to take note that the milk or yogurts or milk-like products will also have some carbohydrates in them. So looking at specifically what you're going to choose in the supermarket, reading the labels is also important. So how can we really make this look like real food? These are just two options, and we can make hundreds of plates with what we just saw, and using that kind of like as a key. And this is where we can make it very individualized for you, and you can take note like the 50% on one side, we have more of the cooked vegetables. On the other side, it's more of a salad. And then one side we chose the rice as the carb or the starch, and then the other side was potato. And then last but not least, we have the chicken or the fish. So what else other than nutrition? We know with nutrition it can affect your blood sugars, and we can definitely make adjustments with what we're eating and the quantity and the quality of the carbs that we're having. But it also goes to show that exercise makes a big difference. I always tell my patients if we can exercise, we don't have any limitations to do so. We definitely should be at least 150 minutes or more for the entire week. So that will be kind of a good baseline. If you notice you're not really at the 150 minutes a week, then that could be something we can start to incorporate more of. So why do we want to exercise and eat healthy? It will improve not only your blood sugars, it'll improve your blood pressure, cholesterol, and your weight as well. So we know a lot of people who have type 2 diabetes probably are overweight or obese. So we also want to make sure that we're managing weight, because we know that if weight comes down, even 5 to 7%, your A1C will also come down, and other metabolic factors will also improve as well. When it comes to exercise, ideally, we want to have a mix of both cardiovascular and resistance or strength training, which can be using your own body weight, or it can be using bands or something like light weights as well. Whatever really works for you. I like to tell my patients, whatever you enjoy doing for exercise is what we want to start with, because if it feels like a chore, then you're not going to do it. And it really has to be more of a lifestyle change at the end of the day, with both the nutrition and the exercise portion of things as well. Then we have alcohol. So alcohol is probably a topic of conversation a lot, especially this time of year where we have a lot more like parties, gatherings, social events because it's the holidays. So how does alcohol affect your diabetes and your blood sugars? So first we have to define what the moderation is, because moderation can be different than from one person to the next. But the defined moderate drinking is 1 beverage for women per day or 2 beverages for men per day. And the size also can vary, but for wine, it's about 5 fluid ounces, 12 fluid ounces for beer, and 1.5 fluid ounces for spritz. So the risk of excessive drinking, which would be considered more than 3 drinks a day, it can raise your blood sugars and in turn raise your A1C levels as well. We do have a risk of hypoglycemia, and hypoglycemia is defined as low blood sugars. So when your blood sugar goes too low, some signs and symptoms are feeling shaky, sweaty, you can't think straight, or you're very irritable. And we definitely are higher risk if you have or you're taking any type of insulin or sulfonylureas as well. Your liver prioritizes alcohol metabolism over the glucose regulation. So that's basically the mechanism of action of why drinking can be really high risk, because your liver is not giving basically the glucose regulation that it should, and it's focusing more on the alcohol, which can cause the low. So then the carbohydrate content, depending on if you want to drink socially, but being mindful of which ones you are having, it depends on the drink. The drinks that are going to be higher in carbohydrates will be like sweet wines and mixed drinks, of course. And then wine and spirits will have lower carbs. And then a general advice is making sure you're eating something with the alcohols to avoid hypoglycemia, monitoring like your symptoms of hypoglycemia, like we reviewed, and monitoring your blood sugars, and focusing more on decreasing quantity overall. So maybe every weekend, let's say at a tailgate, you have 5 beers. If you can go down to 2, that makes a big difference as well. And now we have what I do every single day at Lennar for the University of Miami, the Diabetes Self-Management Education and Support Program. So we have this program, which is also in accordance with the American Diabetes Association, and it helps patients and participants set and track goals to manage their diabetes, working with a diabetes educator and at an individualized approach, as well as classes that will start rolling out in January. It builds confidence to manage your diabetes, which looks different for every single person. Maybe someone knows how to carb count. That's not really a topic of conversation that we need to go in depth with. It's something else. So it's very individualized approach as well. And then also integrating the care for your diabetes in your daily routine, which can change. Not every day with diabetes will be the same. Even if you do the same thing over and over every single day, your blood sugars may not be the exact same, which I know is frustrating. And then it also helps to seek a little bit of community support from your family and friends, and also your healthcare team as well, because we are here to help. I do want to show what I have here is the little food models, which I actually have in my office. And it's really nice to see portions in real life, and kind of talk through which foods are carbs and things like that.
Thank you, Elizabeth. That's great. And I'm assuming on our website where we're driving people, they can get this information to the ADA guidelines and what good nutrition is, right?
Yes, definitely.
So they'll have a look at that afterwards. But right now, let's welcome our next speaker, Dr. Rodolfo Galindo, an associate professor of medicine at the University of Miami and director of the Comprehensive Diabetes Center of UHealth and Diabetes Management for Jackson Health System in Miami. He specializes in diabetes, obesity, and CKD management with a focus on diabetes technology. Supported by the NIH, among other organizations, Dr. Galindo has over 120 peer-reviewed publications, abstracts, and book chapters. What a privilege to have you with us tonight, Dr. Galindo. You're up.
Thank you very much, Ileana, for being our partner with UHealth and being a proud University of Miami alumni. So thank you for helping. Thank you for organizing these. And I also want to thank the U-Health communication team, which people don't see, but they are behind camera, and they are really the reason why we can do this. I merely know how to treat people with diabetes, so I don't know how to do anything else. So I'm very thankful for all the help that we receive from everybody. As Ileana Bravo, our host mentioned, yes, I'm a specialist in diabetes. This is my passion. And then I'm going to be presenting a little bit of how to find out if you have diabetes, if you have risk, and then I'm going to be explaining a little bit about the two main types of diabetes. I work very closely with Elizabeth, who is our right and left hand. Diabetes is not a disease that you can cure by just one person, the physician. You need to have help from other people. In fact, her certification is diabetes education and care specialist. And on top of that, she's also a nutritionist. So we are very fortunate to have her in our team. But anyway, so the topic today is to talk about what you need to know about diabetes, and I will be presenting very basic information that is from our own our curriculum, but also from the American Diabetes Association. We are an American Diabetes Association certified diabetes education program, so which is not everybody had that certification. So I want to start talking about how to find out if you have diabetes. For those that are connected and have diabetes, they may already have a similar story, but then basically the first step is to talk to your doctor. So of course, you would not be talking to me, you will be talking to your primary care physician or other specialist. And then first, just try to get regular step, because most of the symptoms of type 2 diabetes or type 1 diabetes are none. So you will probably don't have any symptoms, although there are a few of them that we'll be discussing. But the first step is to have a screening. A screening is basically trying to do some testing so we can detect the disease before it presents itself with symptoms that you basically will have later in the disease process. So it's always good to detect diseases early, because you can actually do much more. And that is basically what we're saying here. The classic symptoms of diabetes, whether it's type 1 or type 2 or other type of diabetes, is basically feeling more thirsty than usual, feeling very hungry, even after eating, or feeling really tired, or having blurred vision. And then some people may have frequent infection without an obvious reason. They don't know why they keep getting these minor infections. It's not having COVID every month. It's different infections, for example, skin infections or something like that. And then some people will have numbness or tingling in the feet, which is basically a complication of diabetes. So they already had diabetes established for some time. There are many data, scientific data, showing that we diagnose specifically type 2 diabetes a little bit late in the process, actually 5-10 years after the disease process already started in your body. So the first step is to go and talk to your primary care physician and get checked. There are national guidelines, international guidelines of who needs to be checked, and I'm going to be discussing them in a minute. So how we diagnose diabetes. So the hallmark, the main finding of people with diabetes is having high glucose. So glucose is very important for the human body. We need it for generation of energy and to function. So the body needs sugar. So the body uses the sugar and change it into little molecules that is used by all the organs. When you don't use that glucose or sugar properly, is running in your bloodstream, and then the levels go higher and higher. When you have excess blood sugars in your bloodstream, basically that is what triggers complication, because that excess glucose in your bloodstream, in your blood vessels, need to go somewhere. And it gets accumulated in the eyes, it gets accumulated in the blood vessels of the heart, the eyes, the kidney, the nerve, and then those are the complications of diabetes that I'm going to be mentioning later. So the most commonly performed test that you will hear about for diagnosing diabetes is the hemoglobin A1C, or the A1C, or the glycated albumin. So it's a blood test. There is actually a point of care where you can get a finger stick and 1 drop of blood will be enough. Not being the perfect test, but it's helpful as well. And then the magic number is more than 6.5% or higher would be the cutoff defined by the American Diabetes Association. to diagnose diabetes worldwide. So the whole world uses the American Diabetes Association classification of disease. So it's very, very reassuring. And then the other test that people can have done is a plasma glucose. So you go to get blood work fasting, and then fasting, you get some blood work for routine testing. Some people actually get it done before they need a surgery or something, and then they find out they have high fasting glucose. Excuse me, and the cutoff for that value will be 126. One value is always, so this is why medicine needs to be done by physicians and not computers all the time. You need to put that into a context. Some people will have a wrong test or a wrong situation, so one value is not always enough. But anyways, the other test that is rarely performed in most people is the oral glucose tolerance test, where people get they go to the lab and they need to drink a very sugary drink to raise their sugars if they're gonna raise it, and then check after that. We don't do it very often because of the inconvenience, except in pregnancy that we're doing a little bit more. And also, if you go to get any blood work and they do glucose and the glucose is very high, more than 200, well, not very high, but a little bit high, more than 200, that would also be considered. All of these need to be, again, put into a context. Many times we need to repeat it. One test alone will not be enough in many situations, okay? So let's talk about the main two types of diabetes. There are many of them: type 1 diabetes, type 2 diabetes, secondary diabetes. For example, if you don't have a pancreas because of whatever disease, you don't make insulin, then you have diabetes. That is called secondary diabetes. People with pancreatitis and inflammation of the pancreas would also have diabetes if they have repeated episodes. So the other issue is gestational diabetes, and people sometimes that take medications will be exposed to have diabetes. So the main causes are type 1 and type 2. And then type 1 is basically what is traditionally being considered an early disease, early age disease, mostly diagnosed in young people, but it's not really like that anymore. We have many adults with the disease. And the symptoms in type 1 are similar, just a little bit more acute, more remarkable, more pronounced. So if you're feeling, it would not be a slow process of feeling thirsty and tired and all those symptoms. It would be like one day you will feel really bad and the sugar will be really high. And then these are the symptoms. But what is really important is understanding what causes type 1 diabetes, because there is ways to detect if you have a higher risk. So type 1 diabetes is an autoimmune disorder where the body produces antibodies that attack the beta cell producing insulin in the body. And then there is a known risk. So if you have a family history of people with type 1 diabetes, then you can get a screen, you can get tested for the antibodies and also blood glucose. And if the antibodies are positive, there are steps that you can do to prevent having a full-blown disease one day presenting without you knowing. And actually now there are medications approved for prevention of having type 1 diabetes later. It's not 100% perfect, but it's a step forward. If the antibodies are negative, then basically we need to find out another ways to diagnose you. Maybe it's not type 1 diabetes. But the key message here is that there are ways to find out if you have the antibody that one day will produce type 1 diabetes, even if you don't have high glucose, which is the disease manifestation. Okay? So the second most common cause of diabetes is type 2 diabetes. This is about 90% of the population. And then the prevalence of type 1 is like 5-10% depending on the populations. But type 2 is basically what we see most of the time. So that one is more related to the fact that all humans produce insulin, but if you cannot use it properly, and it's not enough. What that means, we call it insulin resistance. So your body creates resistance to using their own insulin, and then you need to produce more, and you need to produce more, and you need to produce more until the pancreas get tired, and it cannot compensate anymore to produce more insulin to lower those glucose values that are really high. And that is basically a slow, ongoing process that people would develop over years. And that's why we say that we diagnose it later. So here is just an infographic. So you have genetical predisposition. There is not a specific one gene. So there is no way for us to say you have one gene, you get type 2 diabetes, but it is a separate genetic predisposition for many genes. So it runs in families as well. Excess adiposity or excess weight is not just being have a large body is having excess adiposity, excess fat tissue deposit in the wrong places in the body. Those factors will lead to that insulin resistance, and then the body will try to make more insulin until one day cannot do it anymore. So that's why it's a little bit more, slow process of going on. So sometimes it takes years to be fully blown presenting. So that's why it's also very helpful to get a screen. What are the risk factors for type 2 diabetes? So for type 2 diabetes, it's basically having pre-diabetes, which is the pre-state, or people that have diabetes during the pregnancy. As we age, our beta cells secrete less insulin and get tired. So you have the genetic factors, the excess fat deposition, the pre-diabetes, and you getting older, it's likely that you will have a higher risk. So some ethnic and race groups like Hispanics, Latinos, African Americans, and the Native Americans also. If both of your parents or sisters or brothers have diabetes as well, if you're overweight or have excess adiposity, as we want to call it this day, we feel that obesity is very, sometimes not the best term, but it would take some years that we change the term. Not really being very active, whether you cannot do exercise or you cannot ambulate, so many risk factors from there. Another condition. So basically, if one of these conditions is present, then you have a higher risk. And then what happens when the body cannot compensate anymore and you have high glucoses, as I explained earlier, it gets accumulated in different places in the body where it should not be. And then we get mainly in the blood vessels. So that's where it starts getting changes. And it's basically a vascular. Diabetes complications are basically blood vessel complications of prolonged high blood glucose. So it can happen in the brain. It's the #1 cause of strokes in the country. It can happen in the coronary, the arteries that give blood to the heart. So the #1 cause of heart attacks in the country. It can happen in the arteries in the kidney. The blood vessels in the kidney is the #1 cause of chronic kidney disease, or CKD as well. In the nerve, if you have nerve damage, you don't feel infections, and then you can get infections in your food. You can also get blood vessels in your legs, also in the gum. It's a very common cause of gum disease, and also in the eyes. So the way we prevent these complications is basically trying to treat diabetes. But for those that are wondering, what can they do? There is a very well validated, but many scientific articles from data from the United States and other countries. Is a risk calculator. It's available on the ADA website. If you scan this QR code or go to diabetes.org, diabetes risk test, or actually in our website as well. So you can check, and then this is basically the question they're going to be asking you, is basically putting there the risk factors that I was mentioning before, and then that will give you a score, and then the recommendation is to get tested. So you either do the test or you go to talk to your primary care physician. So either way will be fine. So how we start working on preventing the complications and treating diabetes. So you need to choose being a better, have a better lifestyle. So Elizabeth is our right hand on this. She discussed very heavily and very well the dietary recommendations and changes, monitoring your weight. And then there are many medications that we can have, that we can offer. And that is actually one of the biggest changes over the last 5-10 years. We have a couple of videos on our website showing that there have been many revolutionary treatment changes in the recent years for people with type 1, for people with type 2. And for people with type 1, actually, it's being a revolution in technology. We have right now a lot of diabetes technology. That means continuous glucose monitoring, insulin pumps. Elizabeth works with all of that because it's part of being a diabetes educator and a specialist. And people with type 2, we have many agents. It's so famous, Ozempic and the saga. It's not just Ozempic. We'll discuss that in a minute. But there are pills, there are insulin for people that actually need it, and there is also injectables that are not insulin. So realistically, I've been doing this for a few years, and over the last 5-10 years, the change has been terrific. Ozempic famous came to the media in 3-5 years ago, but it's actually been available longer. So it's actually not a new agent. So we have many years of data with those types of medications. And then the goal is to feel better. So if your diabetes is better and you don't get the complication, you live a better life. Indeed, yes. So diabetes can increase and shorten your lifespan and your life expectancy. So it's not a simple thing, but realistically, most people will have complication before they get to that. So the main goal, the first goal from our team is to make you feel better, don't get the complications. And if you do get them, try to have a better life and then prevent more complications and change the treatment goals. So for us, it's a pleasure to help people. And then we do a comprehensive evaluation in our clinics. We have diabetes experts, but we also have cardiology, nephrology, pulmonologists, podiatrists, specialists in the food, and then all of them come to our center to care for our patients with diabetes. So that's why it's called comprehensive. So overall, there are many goals, but to make it simpler for people and for me, because science is advancing too fast, the American Diabetes Association has created the three goals A, B, C, D. A is for A1C, which is the metric of how good is your glucose. And then we try to keep it below 7% or below 6.5%. Nowadays, with the newer medication, you can actually have it in 5%, which is in the normal range. Also controlling blood pressure, because having the combination of high glucoses, high blood pressure, and high cholesterol, all of that will lead to the diabetes complications, right? So controlling your blood pressure is part of our treatment plans as well, and cholesterol and everything else. So I hope that we provide some meaningful information. Of course, this is not a diabetes conference for doctors. This is for patients. So I'm happy to welcome back our moderator and host and our good friend, Ileana Bravo, and then we're happy to answer any questions.
Thank you, Dr. Galindo. Right to the point, and that's what people are here for tonight, right? To get some advice and to calm down a little bit. So let's go right to the matter of a pre-diabetic person. We're now in the Q&A session, people. You see your Q&A boxes at the bottom of your Zoom screen, registrants. Go ahead and enter them now, because you have this unique opportunity with our experts. Some of these have been sent before, so let's start with this one. What can a pre-diabetic person do to lower A1C without becoming diabetic besides diet, exercise, and sleep? All the good lifestyle things. Is medications for someone who's
I was going to guide the question to Elizabeth, because the basis is diet and exercise, but they asked besides that. So I guess that we need to give some advice. So let's just go to the beginning. So there are different categories of wrong, bad, non-normal glucose levels, right? So we call it dysglycemia. So in medicine, we try to come up with these fancy words just to make doctors look different. But so there is normal glucose, normal sugar, pre-diabetes range sugar, and diabetes. So pre-diabetes is a pre-disease state where the glucoses are already elevated. So people without dysglycemia will have glucoses that are less than 100, and A1C that is less than 5.7%. From 5.7% to 6.5% is the range of the A1C that we consider prediabetes, and more than 6.5% is what we consider diabetes. Those cutoffs are not made up, and I'm a member of the national committees and national guidelines. This is based on studies that correlate those cutoffs with complications. I'm saying all of this because prediabetes is not an innocuous disease. It's not a disease, but it's not an innocuous condition. People with prediabetes will have increased risk of complications of diabetes. Of course, not at a very high rate as people with diabetes, but there is increased risk of having complications. So prediabetes matters and is the step that we can actually prevent it. The key point here is the main reason for you to have type 2 diabetes, and with prediabetes is considered only for people with type 2. For people with type 1, we consider a stage 1, 2, and 3. We don't call it prediabetes in people with type 1. And now, as I say, there is a medication that is approved for treating people with a stage 2, type 1. So they need to get their antibodies, they need to have normal glucose or something, and then they come to us, and then we're actually the only center in the area that do it. But this is the different condition. Prediabetes corresponds to people with type 2 diabetes, right? So the main goal here is if you have excess weight, even if you don't look like you're a large body person, Maybe you have excess adiposity in the wrong places. What that means is that you have excess fat in your abdomen, around your liver, around your pancreas, around your kidney. Those are not normal things for humans. Humans are supposed to only have a little bit of fat for when we're fasting, that we don't do it anymore. And when we are starving, because we're supposed to be hunting, genetically speaking. So when you have excess fat, you develop these conditions. And then the best thing to do to prevent progression to diabetes is losing fat. How? Whatever you can do. Diet is the basis, but diet doesn't mean not eating. It means eating better, because if you don't eat, your body becomes hungry. Your brain becomes very hungry, and it will ask you for more food. So it's eating better, food that will make you feel full and thus have low calorie. If you stop eating, the body will fight back. This is a New York Times article. The body fights back. Fasting is good, but not for 24 hours. Human cannot fast forever. And fasting, all this intermittent fasting, means eating less. There are many of them. All of them are helpful as long as you can keep it forever. So it's changing your eating. And then, so the diet is very important. It's actually more important than physical activity. And there are plenty of studies showing that if you do many exercise and you triplicate the amount of exercise and you don't do diet and change what you eat, you still get diabetes. So the key point here is eating better, all right? So exercise is very helpful because, of course, it helps with the whole muscle using the insulin and many other changes. But the main benefit of exercise, and Elizabeth is actually a sport fanatic and an exercise fanatic, is for your heart and your muscles. So exercise is the best friend of your heart. Diet is the best friend of your excess fat and diabetes. And when you put them together, you do better. And of course, there are medication. The main problem is that they are not covered by insurance because it's not considered a disease. So last week, one of the newer medication, one of these weekly injectables, not insulin, was studying people with obesity who have prediabetes. And I'm referring to tirzepatide, was published in the New England Journal of Medicine last week. After 3.9 years, there was a 93% reduction on progression from prediabetes to diabetes taking the medication. And people lost about 15 to 20% of the body weight. But I cannot, I mean, I can prescribe it, but it will not be covered. Anyways, I think that I spoke too much. I will let Elizabeth give some comments, or Ileana, you please cut me off.
No,
This is my passion. Right?
we can tell, we can see that. And we'll talk about the GLP-1 drugs in a minute, because of course, every commercial, every half hour on TV is that. But let's get to Elizabeth a little bit about, because you showed us, you know, the plate and all of this in a perfect world, this pyramid that we've inverted of the carb to the protein and all that. I think there's some confusion with people as to carbohydrates versus simple and complex. So if you could spend a little bit of time on that, and also talk about fruit. Some people say fruit is good, then they say fruit is bad. So let's give us a 3-credit course on this.
Yes, definitely. So there is some confusion between carbohydrates in general. So we have to kind of think of it more as a carbohydrate is kind of like an umbrella term. And then we have two main factors. So we have the simple carbs and we also have the complex carbs. So the simple carbs will be the ones that taste sweet. So things like juices, fruits are considered a simple carb, as well as refined sugar, whether it's purple, yellow, brown, wherever the sugar come from, it's actually sugar at the end of the day. Honey, syrup, agave, all of these things will raise your blood sugar in that moment very aggressively. So those are going to be considered your simple sugars. Then we have the complex carbohydrates. So things like bread, pasta, rice, quinoa, beans, lentils, they don't taste sweet, but they eventually get broken down and used as glucose or sugar in your body. And your pancreas needs to produce enough insulin to actually have it be able to be used in your body. So that's kind of the breakdown of the type of sugars or carbs that we have, the simple and complex, and then breaking down with the fruits. So when it comes to fruit, yes, fruit is a simple sugar. It has fructose, so it is one of the simple sugars that will raise your blood sugar. The example that I like to give people is I'd rather you have a fruit than a cookie any day, because the cookie will be actually more calorically dense, and it's not only going to have sugar, it's going to have fat from like the butter, lard, whatever they had, they added to it. So the cookie will typically be more calorically dense for the amount or portion. But also, let's say you choose the apple. If you have a small apple, your blood sugars will go up pretty aggressively and anyone with a glucose monitor sensors can see that. But I challenge people to add in not only the small apple, but add in a little bit of protein and fat to pair with the fruit. So that could be, let's say, like some almond butter or some walnuts or like a Greek yogurt with some blueberries. So then you're not going to see as aggressive of a spike. You'll see kind of more of like a little hump, which is what we want to see when you eat something, that it comes back down, not so much of like a lot of spikes with the blood sugars. So that combination is really helpful.
And that leads us to this perfect question of a wife, because the wife always has to take the lead, right, with spouses. And she says, my husband has type 2 diabetes and is bad about eating regular meals. To your point, we know that intermittent fasting has some science behind it and all that, but if you're a diabetic and you're trying to maintain your levels, how important is eating regular meals and what should they be? And should we slow down our eating as the evening falls? You know, in other words, eat more and less as we go on.
Yeah, that's a great question that someone submitted, and it definitely depends on someone's life and like their work, what they work in and things like that. So planning ahead is always important to create these regular meals and create the routine. Your body likes to have routine because it is a system. But it depends on if you're using insulin, you kind of have to plan ahead and know, okay, I'm going to use this amount of insulin to cover this many carbs. So we do need to do a lot of the preparation. But as this example is for someone whose husband doesn't really eat like very regularly, if they're having any symptoms of hypoglycemia, then we do need to make sure maybe you're not like really hungry or you don't want like a full meal, but we can kind of combine like a small snack that can then make that window of, okay, I'm only having lunch and dinner, but let's have at least a little balanced snack like midday so your blood sugars don't dip and then you get to dinner and you're starving, because that's what I see a lot in the clinic, like you were mentioning. So basically, everyone's go during the day. It's very easy to suppress your appetite. But then when you're sitting home, you're watching TV, anything that you're relaxing and decompressing from your day, then your body's like, hey, I've done all of this work for you on very little fuel. So then is not when you're like, oh, I'm gonna have a salad and chicken. That's when you're like, oh, these chips look good. Oh, this cookie looks good. So definitely trying to create a routine and a habit, and maybe that's asking people for support and help, like a spouse or a loved one, to kind of help prepare certain things ahead of time. Because if you have no plan, then it's very difficult when we have so many options and abundance with food that we're going to make the best decision possible. It does become a little harder when we have too many options.
And I know that you're going to tell us that a perfect snack is fill the center of your palm with a few almonds or something like that, and things that
That's
are
a great snack.
that are not sugary. All right, so Dr. Galindo, let us get right to it. Medications for type 2 diabetes, right? The GLP-1 drugs are through the roof. Is Ozempic effective for these? Are there others that are now on the pike and you're excited about?
All right, so the Ozempic is family. So the first incretin that came to the US market was in 2005. So these are no new medications. So these are very old medications that we diabetologists have been very excited about for many, many years. It's just that the new medications in these families are way more potent, and they have been able to show effects that the prior ones did not show us. So this is not Kim Kardashian tweeting last month. This is 15 years of use and 30 or 40 years of research. So we know this, right? And it's actually very interesting. One of the scientists in New York City, affiliated with Mount Sinai, where I was a faculty as well, went to discover one of these incretins in the saliva of the lizard in Arizona, right? So very interesting for people to read, Google it. That was not the first step, but anyway, it's very, very fancy. Somebody from the US, Sinai and the VA system was able to discover this, and there was one of the first molecules developed through that. So in the saliva of a lizard in a reserve in Arizona. Amazing, right? So anyways, I'm saying all of this because Ozempic is not the only medication. Ozempic was the first to show a big change in many other aspects. So all these medications were developed for diabetes, for like pharmaceuticals, probably from a commercial perspective, because every 1 to 2 people every 10 in the United States had diabetes. And then they find out, and we find out because I did many of these studies, that they have many other effects. So they have effects in getting your diabetes better, making you lose weight. Of course, if you lose weight, you will get your diabetes better. And then they start showing that they prevent heart attacks, strokes, kidney events. They decrease your liver fat. They make you lose weight, and then you have less sleep apnea. Was a paper published last month in New England, less arthritis of the knees. So many other things, because all of these have been complications of excess adiposity for years. All right. So Ozempic is called semaglutide, and it has 2 names just for the sake of commercial and the FDA requirements. Ozempic is the brand name for diabetes. The same molecule is called Wegovy for weight loss. Same molecule, a little bit high dose, same molecule.
And how
The-
about Mounjaro, doctor?
So Mounjaro is similar. Mounjaro is not actually a GLP-1 alone. Ozempic is a GLP-1 stimulant. So it stimulates the GLP-1 receptor, as the other ones is just that it's very potent, right? The next step was the Mounjaro saga. Mounjaro combines GLP-1 with GIP, which is another receptor that was actually the first to be discovered in 1990s, 2000s, right? So it combines GLP-1 with GIP. And of course, it's a little bit more potent because, of course, it stimulates. Mounjaro, the same thing. The pharmacological name is tirzepatide. Tirzepatide is called Mounjaro for diabetes, Zepbound for weight loss. They are really effective, but there are already 8 to 9 molecules in phase 3, which is the last step before the FDA review the data for approval. And many of these studies are already being completed this year on development. So there are 3 from this Mounjaro family, there are 2 from the Ozempic family, and then many other companies, about 8 to 9 molecules already on phase 3, meaning that we are likely to have similar molecules available and FDA approved within 1 or 2 years.
And these would be specific for the diabetic patient and another group for the overweight, or they go hand in hand?
So to me, a diabetes doctor, and we already have these, we have done programs on these. I believe that they go together. Excess adiposity and obesity causes type 2 diabetes, so I believe they go together. But the FDA wants them to be separated, and then the companies need to do the same study twice. For people with diabetes with one specific metric, for people with obesity with another specific metric, and they will be like that until I don't know when. The issue here is that for 30 years, the way to treat diabetes was I will lower your glucose, try to get it to normal range as much as I can, because the drugs that we had at that time were not bringing it to normal. They would bring it to really low sometimes, right? We were doing that for 30 years, trying to normalize your glucose, and it's not enough. These medications lower your glucose to normal. They cause very little low blood sugars, very little hypoglycemia. So they are safer. You can actually get to lower levels because it's safer. And they also have all the additive effects, meaning the cardiologists are using now this medication because it prevents heart attacks. The kidney doctors are using it because they just published the FLOW trial, and they presented at the Kidney Week conference because it prevents kidney disease. So they have many actions because there are receptors in the human body in many places.
So what we're saying really, doctor, is that medical science is going in, I mean, at such lightning speed that is it almost safe to say that diabetes 2 will be almost like, well, it's already a chronic disease, but will be so treatable that it will not be as dangerous?
So these medications, along with other class of medication, is called SGLT2s, have changed the history and the definitions. I cannot say too much because I'm a member of the committees and I have conflicts with the societies, but we will be reviewing many definitions. So we usually talk about remission of type 2 diabetes. We need to revise it because we didn't have the right tools. Do we need to now start talking about true prevention of diabetes, like treating pre-diabetes? So as I say, this study that was presented at Obesity Week 2 weeks ago, 93% reduction. 3 people, if I'm not mistaken myself, on the arm that was receiving the Mounjaro medication developed diabetes. Like it is like nobody, like less than 1% of people. So we are now able to really prevent diabetes.
Yeah.
So yes, so I anticipate that in 10 years we will have much less diabetes, of course, with drugs.
Yeah.
My first approach is you can do it with diet, you can do it with exercise, you can change your lifestyle. Of course, it's better, but do not wait for that to change. The human brain is always hungry. Humans are made to be hungry and to eat. So this is not you wanted to be eating more. This is your brain asking for survival. We're supposed to be eating to survive. So the nature of the human body is to retain energy and to eat more. So if you cannot change it yourself, you need medications, and that will help you not getting the diseases. And yes, in 10 years, this will be a different story. Less people with diabetes and very easy to treat because at least much less people will need insulin. That is a fact. Already is a fact.
Eh, Elizabeth, I know you're answering a lot of questions here. Well, why don't you share with us a couple of the things that people are asking, like even can I order my food in the mail because I don't want to make it at home, or share some of their thoughts.
There are so many good questions here, and some of them, I mean, it's so hard to answer directly because I need more context too. But definitely there are so many meal plan kind of options that if the cost is right for you, if the area that you're in is right for you, then there are different like meal plan options that are available, which can ease a lot of the burden of like, what am I going to make today? Or if you're rushing and you're always eating out for lunch, let's say, if you work in an office setting. So that's definitely an option. There are some other good questions like about coffee, and I get coffee questions all the time. And I love coffee, but it really depends what you're putting in the coffee. So if we're doing a lot of like the creamers with whatever flavor of the holidays they have here, or the harvest, whatever creamer, and then we're adding a bunch of sugar, then the coffee may not be the best thing, because right at the start of the day, we're just getting a dump of caffeine and sugar, which caffeine really isn't a form of energy. It's kind of fake energy. So we have to really be careful with that. And then also what we're adding to it. So I always tell people to be mindful as well of what you're adding. If you need sugar, maybe we can go from like 3 tablespoons to like a half tablespoon eventually. And it takes some time to make these adjustments as well. Another thing is, especially with people who have type 1 diabetes, even if they have black coffee, the caffeine content can affect blood sugars as well. So sometimes we do have to kind of factor that in, because people do get frustrated. They're like, I just had black coffee this morning. I have no idea why my blood sugars are high. And that could be the case because of the caffeine.
Are there any supplements, and here's a great question that just popped up, any food supplements that can help lower glucose levels
I
besides?
can comment on that.
Please.
So yes, the answer is yes. So living a healthy life, having less stress, drinking less sugar, not using corn syrup, not drinking carbonated sugars, and all of that makes you thin. There is some scientific medical data that cinnamon and other things. The problem is that it's not enough to treat the disease. You will never question your cardiologist to treat your high blood pressure with supplements. People do pay attention to the high blood pressure. People do not stop taking their heart attack medications. People do not stop taking their stroke medications for supplements, right? So diabetes is a silent disease. It gives you very little symptoms, and the symptoms are complications such as a stroke, kidney failure, blindness, dialysis. Do not stop taking your medication to go supplements unless you can do it with your lifestyle changes and everything else. So I'm not saying not to take it. This is for my grandmother who taught me many, many things in medicine. It works, but it may not be enough. That is the issue. Do not rely on taking just Jamaican bush tea and stop your medications. If you lose weight, you eat better, you do exercise, and you take the Jamaican tea bush, and it works. Some of them, by the way, go to the FDA website and check, because some of these supplements have already been reported to cause bad diseases, liver failure, bleedings, and so on. These are not regulated medications. They have not been tested. The only available scientific information is what the companies want to publish, because they are not mandated to do so. So if you go that route and you want to take supplements, do please check that they are safe. I personally don't say no, but I would not stop taking proven medications to go cold turkey the other way. I'm sorry, Liana, please.
No, because I'm seeing the drugs such as Jardiance and the other ones like that. Are those now recommended for pre-diabetics?
So no, Jardiance is a different type of medication that is also a life-changing disease, a life-changing medication. So Jardiance, Synjardy, which is a combination, Farxiga, all of these medications are in the family of the SGLT2. They work in the kidney. They make your kidney get rid of the high sugars. That was how it was developed. What we did not know, or maybe didn't pay attention to it, is that they changed the whole kidney functioning. Excuse me, and that's why they are so good, probably much better for kidney and heart disease than diabetes. But the studies took longer. So again, SGLT2s, different kind of medication developed for diabetes, but excellent for your kidney and your heart. It is actually more prescribed now by heart and kidney doctors than diabetes.
And is Trulicity in this group too? Because there's a
The
question.
GLP-1 family include Trulicity, Mounjaro, Ozempic, liraglutide, Saxenda. All of these medications, they work in a different pathway, mostly through regulating excess weight and many other findings. But they probably together are gonna change the life of people with diabetes. Because
And here's the question.
Go ahead.
And here's the question that people are saying, so I've taken this one, the glipizide or the Jardiance and others with the Mounjaro, I've lost the weight, my A1C is under control, I've been taking it for 2 years, for 4 years. Do they get to stop it?
So on the studies that were done to get these medications approved, there was a step where medication were stopped, right? And people were checked a month later. And other studies were stopped and people were following the study for 1 or 2 years. You stop it in 1 month, the A1C goes up. Not a big jump, but it starts going back up, right? This is what I'm saying. Nobody will wonder if they can control the blood pressure by just walking. They will take the blood pressure medications, right? However, if you have lost the weight and you have changed the way you do it, and you can do it, my family had done it, okay? I'm not gonna say many things that are very personal, but my family had done it. If you change the way you live, when you lose the weight, you may be able to go to a different medication or lower the dose or do something alternative. The issue is that those studies are now being conducted. I practice and I do it some ways in the office, but based on my experience, but the studies for the maintenance doses are now being done. We're still doing the studies to get the new medications approved. Very quickly, Trulicity is in the same family of the Mounjaro. It's actually the step before Mounjaro, not as potent. Liraglutide, Victoza, or Saxenda is the same similar molecule to Ozempic, a little bit a step before. They are not bad. They are just not as potent as the other ones, okay?
The exciting news is that we're doing a webinar tonight, and we're talking about basically getting to cure rates. We're not there, although Diabetes One certainly has. So we have to thank you for the privilege of your time. You have been incredibly helpful to us and eye-opening, and the people can see the hundreds of people who joined us tonight. There's the information on their screen, how they can get in contact with you if they want a dietitian or the full spectrum of services. umiamihealth.org/diabetes. Appointments 305-243-3636. Take a picture of the QR code and it'll take you right to it. Thank you, Elizabeth, Rodolfo. You were magnificent tonight. We can't thank you enough.
Thank you very much, Ileana. Very quickly, one question on the chat on type 1. Everything that I mentioned is about type 2. Type 1, we're a little bit behind, but still, as I mentioned, there is already a new medication for people with stage 2 or type 1, but a different lecture, different conference. But anyways, everything that I say referring to type 2. I thank you very much for everything that you do for us. And I thank you, Elizabeth, for just following my ideas and my dreams and my crazy tricks. But this is basically what we love to do. And we welcome everybody that needs some help.
The passion shows. Good night, everyone. Stay healthy and safe out there and make it a good night. See you soon.
Thank you. Good night.